Good afternoon and welcome to this very interesting session. So spinal injection techniques are a great armamentarium for orthopedic surgeons. Basically, between the conservative treatment and the surgical treatment, the injection techniques fall somewhere in between, which provide patient not only the pain relief, but it also helps us in sometimes diagnosing the actual cause of the patient problem. So I had this patient, 42-year-old male, severe leg pain for last 2 months, tingling, numbness, paresthesia, perfect indication for the surgery. However, the patient was not ready for the surgery. So what to do for these kind of cases? Another patient, 30-year-old female, severe neck pain, no neurology, no radiculating pain. She had tried physio, but nothing was working for her. So in my book, this is not a surgical case, but patient is still in pain, so what is to be done next? Third patient, 65-year-old male, right leg pain. Patient has multi-level pathology. So should we subject the patient for a multi-level surgery, or because of the recent onset right leg pain only, should we try to find out the exact cause of the pathology and try to treat that only? So certain situation where we want to minimize the surgery and kind of pinpoint what is the root cause of patient's actual problem. So in those cases, I think the injection techniques are very careful, very useful. In this particular patient, we did a right L4-5 foraminal block. Patient responded very nicely. So we just went ahead and did a L4-5 discectomy. There are situations when the patient wants to delay surgery for personal reasons or for multiple other issues. And in certain situations, we don't have good surgical options available, like in the cases of sacroiliitis or facetal arthropathy. And so these are the multiple scenarios where we can utilize the injection techniques. They have both therapeutic as well as diagnostic value, and there are myriads of procedures. So let's have the star faculty from our session, Dr. Ingalhalikar sir, to throw us some light on, to understand the basic anatomy of the injection techniques, how and when we try to approach the things in a particular way. Ingalhalikar sir.
Good afternoon, ladies and gentlemen. Right at the outset, I would like to thank WIROC Organizing Committee for keeping this particular topic. It's an extremely useful modality of management of back pain. Like Amit said, diagnostically as well as therapeutically, it's very useful. And if you understand the basic tenets of that, you would understand the anatomy three-dimensionally. The chance of you performing those successfully is always improves. The more accurate you give it, more effective they are, and therefore our goal is to improve their effectivity. The first question comes is, can we do it without CIAM? Well, except caudal epidural, others can be done without CIAM, but otherwise most of them would need CIAM. The next question people always ask is, how safe is that from radiation point of view? There are plenty of studies in the literature. These are 3 hallmark studies where they have studied more than 300, 400, 500 people. And their conclusion is the average exposure during these procedures is below the allowable limits when all precautions are taken. Then what are the precautions? Well, you must follow the radiation protection protocol. You must use the lead apron. You must keep hands off the beam using long-handled instruments. Here you will see the sponge holder. You can see the sponge holder with a long handle. My hand is here. Needle holder, my hand is here. And therefore, we are trying to be as far away from the direct beam thing. Then we shoot the pilot image using auto exposure, which most of the CMs now have. And then reduce the exposure. Once you reduce the exposure, all the remaining adjustments need to be done through the changes in the monitor, brightness, contrast, etc. Now you go and adjust it in the brightness. Therefore, you will be able to use only the loader. Instead of using a continuous beam, use pulsed or intermittent exposure over, say, every half second, etc. You will still be able to do a good job of it. Another important thing that they have recommended is, don't do these procedures daily. Do these procedures twice a week, thrice a week or so. So you take a moratorium or you take a break between 2 days, and if you can space it out, your exposure chance grows. If it's a question of doing the thing accurately, because we do lumbar spine more often, because we do lower lumbar spine often, because we do it in obese people version, the quality of image intensifier is an extremely important point. So you must have an optimal, good quality image in the lateral view of the lumbar spine. In an obese person, that's the least quality you want out of image intensifier. Generally, it boils down to the capacity of 100 kV and 5 mA. It must have all axes of smooth movement, and each axis movement must be independently lockable. You must have a flicker-free dual LCD monitors with lots of adjustments. All modern monitors have lots of image adjustments we should be able to do. The whole setup must have an ability to shoot video, and because of that, you must have a good memory capacity in that. Upon all that, you must have a well-experienced C-arm handler. C-arm adjustments are very, very crucial, and therefore either you yourself become one, but when you wash up, you can't do it, but you train people so that you must have a well-experienced C-arm handler. Table-wise, because we go from dorsal lumbar junction to lumbar area, etc., we need the central post of the table terribly eccentric. Only then you will have no obstruction of tilting your C-arm any which way you like. The table must be broader than the normal operation table. Normal tables are about 21 inches. It should be broader because the metallic frame of that table can obstruct your vision, especially in oblique views, etc. And you must have, patient should be more comfortable in broader one. Patient's position-wise, people have suggested various positions, but we prefer to put the patient completely prone in a stable position with the pillows underneath, his arms rested, etc. That way, patient doesn't know when you put in the needle. And if you put in a needle, patient moves, there's a problem. So patient's compliance is really excellent. And whatever manipulation you want to do, whatever imaging that you need to do, you do that by moving, tilting, and rotating C-arm. Well, if this is how we prefer to keep the thing, I am standing here. I am able to see beyond the monitor. The monitor, the tube head is here, and there's sufficient space between tube head and this, and I'm able to work up. So I am standing comfortably, patient is sleeping comfortably, there's no obstruction to the vision, and there's no obstruction to my functioning here. That's the position in which you work. You must become familiar with orientation and morphology of the vertebral body, the end plates, the pedicles, the facet joints, the pars, the intervertebral foramina. And all these in every different exposures, like AP view, in oblique view, in lateral view. And therefore, you, in order to tell the technician, इसको ऐसे घुमाओ, और 2 degree घुमाओ, और थोड़ा ऊपर करो, you yourself must be a good technician. Okay. When you try to see this, if for a best thing, you must have an image which is in the center of the screen. If this is my index vertebra, where I want to do, the patient's image, patient is sleeping prone, therefore patient's left side is towards me, right side is towards me, cephalic end is here, and that's exactly how I want the image on the image intensifier, like a patient is sleeping. Then you must have, while performing one movement, you must lock the other movements of the C-arm. Otherwise, the whole setup gets like that. The C-arm generally has a horizontal swipe. Try not to use it because that can vitiate the image. It also has ability to rotate around its own head axis. Don't do that. Both those things will vitiate the image. You'll get into difficulty. Well, this is how you will start looking at this. Look here. The spinous processes must be in the between the two pedicles in the center. The both pedicles must be equidistant from this. Then you must have a clear space between the top of the pedicle and the end plate, and you must have much larger space between the lower end of pedicle and this clearly. Once you have this image, this is the best way you can access, or safely you can access various things. The concern edges and end plates, as you see here, they are, this is a parallel plate, the anterior part and the posterior part of the end plate, but as you go up, it becomes duplicated. At the index place, you must have a minimum of duplication. That means you are squaring it properly. In other views, like oblique view or thing, they will not be parallel, but see that there is no duplication here. It's a single plate, or also here, single plate. This is a facet joint as seen from behind. These are the facet capsules. I want you to understand this orientation, where it starts, where it ends. This is how the lateral view will show. In the lateral view of X-ray, unless you are really experienced, you will not be able to make out the facet joints because the plane is quite oblique. It's not truly transverse and lateral. Well, nerve supply to the facet joints is a very important story. Look at this particular facet capsule. It will receive supply not only from this particular area, but will supply coming from higher up also. And this can sometimes go only not one, it will go down to the third one. That means every facet joint will have multi-segmental supply coming from above, and sometimes even a branch of this, you can see this branch, sometimes this branch can go up and supply here. And in order to do diagnostic block, you will have to block the central area first, wait and watch. If not, block the lower and upper. And if you feel, now you know you're able to localize which particular area is there. Another thing, when you do facet block, you not only block this nerve, which is extracapsular, you block the capsule inside, you also block this area, and you also block this area, lower area, because those are the areas from over the nerves will traveling in. This is during surgical dissection. These are the branches which are open, which can be easily damaged by your working. This is a typical oblique view. You will find that this is the end-on of the pedicle, as you are seeing here. This pedicle is here. The root will skirt underneath and go out from here. This is one area. This is upper margin of the transverse process, or I would say upper part of the pedicle, this area. Keep that in mind. We always wonder which side, ये कौन सा facet है, left है कि right है? We always keep wondering that. Remember, when you see a particular mouth of that Scotty dog, that means you should be able to see a broadened ileum and not narrowed ileum. Broadened ileum is ileum of that particular side. That's the side whose facet joint you will see. In order to see the other side facet joint, you'll have to broaden this up and take up. On the other hand, if I want to go into the facet joint, SI joint here, this exposure is not correct. I'll have to use this exposure, because it's exactly at right angles to that, and I'll have to change it accordingly. How many minutes we are? 12 minutes. So 11 finished? Okay. Keep the concerned end plates parallel and run arc either ways to the left or right till you see the open space. Then you can tilt the C-arm, or carotid if required. This lower margin of the pedicle and the tip of the superior facet must have a lot of space. That makes it very, very safe and useful. Our exposure point is significantly improving. What we do is we select a safe bony location near the target area. This will be what I call the target point for the needle tip. Keep this point in the center of the scene. Reach this point keeping the needle in axial end-on view, what we call as a coaxial needle travel. Then navigate the tip to the required area. Confirm, reconfirm, and this is what you will find is happening. You see here, this is where I aimed at it, and this is an end-on. Afterwards, I'll do AP view and navigate it within, put in a die, and have a look at the whole area. This is the safest way of doing things. Well, as I said, one important point you remember, amongst the sacroiliac joint that you see on an X-ray, upper third or even upper three-fourth is filled up with syndesmotic fibers. There's no cavity. You will not be able to insert your needle there and it's useless. You will have to go only to the lower part of the SI joint, which has a cavity and which is to be useful for your function. Most of the diseases and pain production areas are here. Thank you very much.
Thank you, sir. Sir, in your practice, which other injection techniques do you use, like in the lumbar spine?
Now, Dr. Chaubey is elaborating on that.
So, and when are you using a facet joint injection? Do you like only use intra-articular injection, or you will be kind of?
He will tell you that.
Okay.
He'll tell you that.
Do we have any other question for Dr. Ingalhalikar, sir, from the audience?
I think at the end we'll have a lot of questions which will be relevant to all three talks.
Okay, can I invite Dr. Bharat Chaubey, sir, for his perspective about from an orthopedic surgeon's point of view, which kind of injection techniques does he use and how we can incorporate them in our practice?
Good afternoon. Majority of the people sitting here have shared one common scenario. And that scenario is the patient comes in your office and says, Doctor, I have visited many, but my problem has not been solved. So can you help me? So this talk is nothing but our approach to help our patients. So what I'm going to emphasize more on the tips and tricks of the individual procedure and some basic aspects which is related to the injection modality. So all of us treat the chronic back pain patients, and we all know that etiology is not always single or one etiology. Sometimes it is a multifactorial. We also know that the medical management is not always satisfactory. So every attempt must be made to localize the pain source. The pain source could be discogenic, it could be facetogenic, and we must know that both the kind of pain source can give the radicular symptoms. Even the disc can give the radicular symptom, the facet also can give the radicular symptoms. So, and whether it is only one disc, one facet or multiple, we must know. So when it comes to identifying the pain source, we must know that all abnormal looking area on any imaging modality need not be correlated with the pain experienced by the patient. So some irritative lesions that may have chemical or immunological basis may be the source of pain. And these are not identifiable on imaging modality. So any considered pain source, even on the basis of precise clinical judgment and the structural information what we have, so it remains probable unless this considered pain source is being blocked and patients say that my pain has gone. That means you have blocked the pain source, you have identified the pain source, and now you are ready to treat the pain source. So this is a modality which solves the diagnostic dilemma by localizing the pain source, by quantifying its relative contribution. And the beauty of this procedure is that it can satisfy the clinician and patient as well. So you all know that our judgment depends primarily on the clinical ground, but it is always supported by the imaging modalities. We also should know that when you are using a 0.5% of xylocaine, then it only blocks the sympathetic fibers. When it is 1%, it blocks the sensory fibers, and when it is 2%, it blocks the all kind of fibers. So when we are mixing the steroid with the local anesthetic, we must know that it should not go below 1% in any situation. Otherwise, we will not be able to block the pain source. So when we are using only for the diagnostic block, we use only Xylocard, and that is the preservative-free xylocaine. But when you are using as a therapeutic block, that is the time we mix a steroid with the bupivacaine, that is 0.5%, so that after mixing, it remains as a 0.25% to block the pain source and give the desired anti-inflammatory effect as well. So you see, on table, we keep all the three: methylprednisolone acetate, bupivacaine, and this preservative-free xylocaine. All of us know that the corticosteroid per se is a useful drug to take care of the inflammation, provided it is judiciously used. So why it is useful? So useful because it stabilizes the membrane potential, it suppresses the ectopic discharges, and by doing so, it facilitates the nerve conduction. We also know that steroid prevents the adhesions and scarring, and adhesions and scarring can impede the blood supply to the nerve. So by giving steroid, we are facilitating the blood supply and preventing the neuroischemia at a later date. So all put together, it reduces the pain, paresthesia, and it improves the function. So local anesthesia and the steroid both desensitize the nociceptors, and ectopic pain discharges are reduced. But steroid per se suppress the inflammation, and all put together, it helps in pain relief. But we always remember that whatever the pain relief period the patient is getting, that must be utilized for the purpose of rehabilitation, for giving long-term benefit, and not merely this short-term benefit of the injection. We all know that there are certain prerequisites of these procedures. So we all know that the C-arm is must, proper positioning of the C-arm, and the proper tilting of the table as and when it is required is very, very paramount importance to make you Arjun so that you can reach the target precisely. We also use the contrast to confirm that wherever we have reached is right. So you see how these tables are tilted as per the need. We use these things for the procedure. And these are the modalities which we are in practice, except the sympathetic ganglion block, which we generally don't do. Majority of us considers whenever there is a back pain, that means it is a mechanical issue. It need not be. The neurogenic back pain is also a very valid entity, and in many of the compressive etiology, the person gets the back pain because of the nerve compression. When there is a compression on the D or G, primarily it is paresthesia, and when there is a pure inflammation, that is the radicular pain. So these particular indications, what we are talking about is in all such scenario, we give these type of blocks. You all know that when we call epidural, that means it is either sacral, interlaminar, or transforaminal. The sacral epidural we are doing for many years, and this is simple to perform, lower risk of dural puncture because the dura ends at S2, requires higher volumes. That is you see that the 10 ml for this level, 15 ml for other level, and that's all. For the sacral epidural, you have to palpate the sacral cornua like this, and then you have to manipulate the needle so that it enters into the sacral hiatus, and finally you deliver the medication at the at the L4-5 or L5S1 or up to the L4-5. So generally this interlaminar approach, wherever there is a resource limited settings are there where the C-arm is not there, or many times the anesthetist, they practice this interlaminar approach through various ways. But generally we are practicing the transforaminal approach, and this transforaminal approach you can see there, this is the transforaminal. So we target, our target is in the foramen. And why so? Because we go through the transforaminal because it delivers the medicine right at the source, anterior epidural compartment, and these things can easily be delivered there. So you see here it is very clear, this particular, if we are doing the selective nerve root block, our needle will be here. If we are going for the foraminal disc bulge, our needle will be here. If we are going for the extraforaminal disc herniation, our needle will be here through the Campbell's triangle. And that is how we select what we want to do and where my target is there. So here it is very, very clear, the lateral to the superior articular process where we go, or we go here, or we go there, above the root, and that has been shown. So to do this procedure, first of all, you have to make the vertebral body neutral, and for neutral, it should look what the sir has already explained. I will not spend time on that. So then we do this particular thing, we oblique it, and then choose the target. Then we confirm in the AP and lateral where we have reached. Then we confirm with the dye whether our target is right or wrong. And then if we want to go for the S1, then we go in this oblique manner and we go and hit there in the obliquity. For whenever our needle is reached at the target, we try to aspirate and to avoid any vascular complications, because our drug should not go intravascular. So for the facet block, first we choose AP, then oblique, and then this Scotty dog appearance. Then we put our needle here, and then we try to bend the needle to make it the hockey stick. And when it comes to the lumbar discography, we choose the Campbell's triangle, and in Campbell's triangle we go, reach there, go enter, inject the dye, see what is the morphology, and then accordingly we do it. Then when it comes to the sacroiliac joint, the lower half, which has already been discussed, see that the two parallel lines are seen, and then we give the sacroiliac. And then we check in the dye whether the dye is reaching in the joint or. So this is how we perform all these things. The take-home message is very clear that the injection modality is an important diagnostic tool. It is not just for the therapeutic role, it has a diagnostic role, and so that we can avoid the patient for unnecessary, unwarranted surgical intervention, and the pain-free state must be utilized for the purpose of rehabilitation. Thank you.
Thank you, sir. So as per Dr. Ingalhalikar's suggestion, we'll take the question and answer at the very end of all the three sessions. Can I invite Dr. Jitendra Jain, sir, for his perspective from a pain management physician's side? How does he approach a spinal pathology from the injection point of view?
Thank you, Amit. Thanks a lot for having me here for this presentation. I mean, there's actually nothing like a non-orthopedic way, but it's just a sound catchy. I think probably that's why the term was put. So basically, I'm just going to take it forward from what Dr. Ingalhalikar and Dr. Chaubey has already spoken about, and maybe a little bit of pictures in terms of lumbar facet, maybe radiofrequency ablation, and for some of the cervical procedures. So I have a book, I'm just using this platform to push this book, basically pain management, basic assessment and pharmacotherapy. It doesn't have much about the intervention, but just to have a clear understanding in terms of how to assess and how to approach these patients before we actually intervene with interventional procedures. Okay. So just one request that we do not call it injection, just to not to undermine the procedure that we are doing. The only other advantage probably I feel is that if you can put it like a procedure, then you can charge more as compared to when you call it injection. I think probably that would be better. So why do pain procedures? Obviously, I mean, pain procedures, you're doing it basically to decrease pain, to assist natural healing of spine, to decrease the pain requirement, painkiller requirement, which actually could be detrimental in some of the patients, especially with comorbidities. Obviously, the diagnostic implication of these procedures is much more useful in terms of diagnosing and planning a definitive treatment later on. The second important factor is that once the pain has improved, the rehabilitation part actually takes care, and that usually improves these patients in the long-term basis. Obviously, the patients who do not want surgery or had surgery still have issues. We can offer these. Diagnostic advantage, which I've already mentioned, some of them would be to come to a conclusion what is generating pain, facet or disc or SI joint, because you can do a diagnostic procedure for those areas and see if patient's pain improves. Obviously, then you can target them with a definitive procedure later on. To obviously, from the surgical perspective, is to identify the problematic disc and attend that particular disc in some of these patients. If these patients improve, we can plan definitive advanced procedure in some of these. Obviously, if the patient improves, then you have an advantage of informing the patient if the surgical prognosis would be better. Because if the patient improves with the diagnostic procedure, especially with the transforaminal, the chances of patient improving post-surgery is much better. Another big advantage of these procedures is that if the patient does not improve, say, from the transforaminal block, then it might be a sympathetic mediated, where we can target the sympathetic chain, or some of these patients we can actually tell them that it could be a psychogenic. So some of these procedures you can even perform sham procedures so as to come to a conclusion and convince the patient that there might be a different etiology than what we are actually thinking of. So commonly done procedures, facet joint block, median branch block, SI joint block. Trigger point injection is actually a very useful modality, which we tend to ignore in clinical scenarios, especially the patients whom have, which we label as non-specific back pain. Some of these patients might be just having tender muscles or trigger muscles, which can be addressed just with local anesthetic, and they might be much better. Once the pain improves, obviously you can push them on rehabilitation. Indications already mentioned. Contraindications, if patient says that I don't want it, obviously you don't give it. And if any coagulopathy or infection, you don't do it. So approach, obviously you come to history first, where you would be suspecting a particular generator and you would be targeting that accordingly. You obviously rule out the red and yellow flags. Examination in general, as for the spine assessment, would be done, but I would insist that a trigger or a tender muscle should be located, because if we can find out that, and if we can just address that by a simple, say, a trigger point or a tender point injection, then we can even avoid an interventional procedure under CMR or USG guidance. Counseling is very important, to talk to patients what to expect pre and post procedure, because they should be informed about the rehabilitation part of it. Because once they expect that we have done a procedure, they think that they've been fixed. They might overlook some of the rehabilitation aspect of it. So positions, prone position, usually for lumbar, I try to put a pillow so as to decrease the lumbar lordosis. This is how a spine, as Dr. Ingalhalikar has already mentioned, squaring off. The Scotty dog, you can see that. You can see the facet joint here. Under C-arm guidance, you can see the target areas. So the target areas, facet joint, transforaminal, and this is where the median branch lies, the dot that you're seeing. So if you're suspecting a facet joint pathology in a patient, you can just inject local anesthetic here, one level below, above, and one level below. So if I'm suspecting 4-5, I would go one level above, one at the level, and the level below. Inject local anesthetic, assess the patient, send the patient home, and see the improvement. If patient is better, I can offer the patient a radiofrequency ablation at a later date, if at all the pain comes back. If pain doesn't come back, patient is fine. This is foraminal block. Foraminal block. So the reason why you do that is, as Dr. Chaubey has mentioned, that it's in the anterior epidural space, you are able to drop the medication actually where the pathology is. Caudal, some of the pictures. You can actually direct the needle, say if patient is having right-sided pathology, you can direct the needle in the caudal space under C-arm guidance on that particular direction and drop the medication so that it's more effective and you are able to deliver the safer dose in a targeted area. You inject contrast to see if you are in the safe area so that you don't cause any complications, especially if you're injecting a huge volume of local anesthetic, which could be detrimental in some of these patients. Facet joint block, inject contrast. It's a very small space, so you don't inject contrast like 1 ml, 2 ml. You inject only about 0.2 or 0.4 ml of contrast, see the spread, and you can inject your local anesthetic and steroid, which is again 0.5 ml or at the most 1 ml is good enough. SI joint block. Now, coming to the cervical space, the patient with neck pain, radicular pain, depending on what the pathology is you're suspecting, you might consider doing a median branch block or a facet joint block, especially if patient has central axial pain or paravertebral pain. And if patient has radicular pain, obviously you subject them for epidural. Usually the position lateral would be for facet joint block or a median branch block. Prone position is usually for patients if I'm considering a cervical facet radiofrequency ablation or an epidural. This is the pathology. You can see the median branch comes here. This is the facetal pillar in the center of it, here. And this is where I'm going to target under C-arm guidance. So when I'm doing a lateral position, we have to make sure that both the facetal pillar, right and left, they're opposing each other so that you are able to see one particular facet pillar so that you're not confused which one you are targeting, the nearer one or the away one. So this is how the facetal pillar will look like. This is your joint target. You can see the dot over here. That's inside the facet joint. And this is where, in the center of the pillar, you'll target it for the median branch, especially the patients who have localized neck pain. Now, once you have diagnosed that patient has median branch, patient has improved post-median branch block because of the neck pain, then you can plan a definitive procedure of RF if the pain comes back. And usually the entry point in these patients, because this, you can see the waist of the facetal pillar, that's where the median branch is. You start 1.5 centimeter below and 1.5 centimeter lateral, so that you go obliquely in the direction so that you're parallel to the nerve when you're considering radiofrequency ablation. Because I want my needle to be parallel to the median branch so that I get maximum of the median branch when I'm doing the radiofrequency ablation. You can see it over here. The needle is here. For epidural, usually the target, you can consider doing it, say, on a specific, say, if it's a left-sided pain, you can start from the left dot. Right-sided, you can direct the needle on the right side. You don't need to be in the center. Unless patient says that he has bilateral pain, you can keep the needle one-sided and drop the drug on one particular side. I'm just having a small video where I'm showing, I use basically the negative interthoracic pressure so as to use the hanging drop method to locate the epidural space. You just see this gets sucked in because of the negative introduction. So that is basically, essentially, I have entered the epidural space. I inject contrast, confirm that I'm on the correct side, and inject the drug. So evidence is fairly good in most of these procedures for short to medium term. Long term, some of these procedures might not be as effective, but most of the procedures are fairly good for short term. Complications, as usual, would be bleeding, infection, anaphylaxis. You have to have. I usually keep, although I'm an anesthetist, but I usually call an anesthetist as a standby. So it's always better and safer to have that. Thank you, and Happy New Year to you all.
Thank you very much, sir. Do you have any questions from the audience side? Go ahead.
Thank you for a wonderful presentation. So just a question, what exactly counseling do you do before offering intervention pain management techniques to the patient? Because a lot of patients, they come and they say that, will it help us to avoid surgery? If Ingali sir will like to share his thoughts.
First thing is, there are about 30% patients. I'm talking about 100% properly chosen cases. 30% patients where a single injection, especially in the facets or transforaminal, would give a long-lasting relief. So they are ones who are going to be benefited. There are others who will have short-term benefit. They will come back again. You've got to prepare them for a second injection. Sometimes the first injection may not give relief, but second may give. But if they don't come for the second injection, they're not going to be benefited. Therefore, you tell them, कि एक इंजेक्शन दे के देखते हैं कितना फर्क होता है, जरूर पड़ेगी तो दूसरा दे देंगे. This is one thing. Second thing, we tell them that, which is a very important thing, that just prior to doing the procedure, we make them do certain actions, flexion extension, rotation extension, single-legged standing and extension, rotation, etc. to find out the maximum pain on which posture, which area. A facet, one facet loading. Then we inject, and within next 5 minutes, we bring down the patient. Ask him to do the same actions which produced pain before. If a pain has gone now, he says, I'm feeling better. You know that accuracy point of view will. So you've got to tell this also to them, that we might inject your two sides, not at one go, we'll take you down, do it again. And again, you'll say that because it's a depot preparations that we use, your relief may come slowly, gradually.
Sir, I've had patient who has taken as many as 17 injections. Taken almost 17 injections.
17?
Yeah. Also, is there any endpoint where you recommend the number of injections the patient should be taken before you advise him surgery?
Well, those...
I don't know, I was just saying that send them to the right person.
Go
ahead. So, 17 injections, that itself means there could be some issue either with the diagnosis or with the patient. There can only be two meanings. So, depending on how you look at this particular patient, you need to have a thorough assessment before considering another procedure for these patients. That's what I can suggest.
You see, basically, I try to make it very simplified. One is the diagnosis is almost clear, but the patient has not responded to the routine measures like physiotherapy, medication. So I say that this is the direct delivery of medication and this should work. And majority of the time it has worked. So in your case also, it will work, like a disc herniation. But I don't recollect patient where the multiple times is needed. Generally, one injection is sufficient, and in hardly any patients, you second time, and I've never given the third time. And another scenario is the diagnostic dilemma. So I tell the patients, I have to diagnose the case first, And once you and me both are convinced, then we will start the treatment. Otherwise, we are not starting the treatment. Then I call for the diagnostic block. And once in the diagnostic block, the patient will say, "Nahi doctor, हमारा तो pain अभी बहुत कम है." Now I am convinced that. So I say, okay, if you are convinced, then I am also convinced, and let us start the treatment. And then we finalize the treatment, whatever the best treatment is there. So this is only two approaches. There is no third, I don't believe.
Okay.
Another thing is, presuming that you have given meticulously and accurately, correctly, and after local injection of xylocaine, patient's pain has gone. That means you have delivered the steroids correct place. If it doesn't work for 2 times, third time probably it's not going to work. Probably it's not. So we
point, would you
generally
advise
don't
surgery
repeat
to
the third, fourth, and 17 injection, I think, is a wonderful commercial venture.
Thank you, sir. I think in the interest, your question. Go ahead.
My question to Dr. Chaubey. So, what is the ratio of bupivacaine and xylocaine?
50-50. 0.5 ml. So I always make it 4 ml. Because the 80 milligram of methylprednisolone acetate, so that is 2 ml. So 2 ml you take the bupivacaine, and whatever you want to inject, minimum 20 milligram of steroids should go at the site, minimum. Otherwise it will not be effective.
So, minimum 20 milligram of steroid at the injection.
At
site.
one site.
Okay.
So 4 ml you prepare the solution.
Okay.
Because otherwise it will be less than 1%, and then you won't be able to know whether it has blocked it or not. Because 2 ml of bupivacaine, 0.5%, and 2 ml of methylprednisolone, both put together it will be 4 ml with the concentration of 0.25% of bupivacaine,
Okay.
which is an anesthetic agent.
I think we'll
Okay.
just take a
Fine,
last
sir.
question from
Thanks,
the
sir.
variant.
Sir, my question is regarding the interval between the 2 injection. At what point of time you consider for a second injection? Will you wait for a particular time period? Your patient symptoms, it demands the injections.
You have to give minimum 3 weeks time for the observation. And in 3 weeks time, if the patient says, I am 50% better, you have the liberty to tell him that I want to give the second injection. If he is 50%, minimum 50% better. If he is less than 50% better, I don't think whether it is a second or third or fourth, whatever is.
Thank you, sir.
Now, giving these injections twice a week or even once a week, once in 15 days, it's not a scientific rationale. Because by the time the solumedrol really gets released and works, takes time. So giving more frequently than once a month, it doesn't really work well.
Thank you, sir. Thank you, Akhil and Abhishek. And I would like to thank you, Dr. Ingalhalikar, Dr. Chaubey, and Dr. Jain again for